cases here. This is a 16-year-old who had an injury 6 years earlier. It was initially diagnosed as a soft tissue injury. No fracture was detected. We don't have the x-rays. But when she was 16, the basic concern was that she had a fixed flexion deformity of 25 degrees, and that's when, they think about getting their children married. So x-rays, these were the x-rays, and the CT scans, okay? So if you look carefully at the x-rays and the CT scans, the main problem was this flexion deformity, okay? So even under anesthesia, that was not correcting. She had a full range of flexion, okay? But even when you tried to extend it, it did not go beyond that. And this is a kind of difficult situation because she has good flexion. Do you intervene? Is that going to cause a problem? How much is the articular step off? You can see the CT scan here shows you articular step off here, which is again a butting on the tibial condyle. So we decided we should do something. So the question was what we would do. And so once we open the fracture, you can see the step off is a lot more than you can make out even on the CT. Okay? So that's the posterior part, that's the anterior part of the condyle. And so now what you would need to do is to create an osteotomy through where you thought the original fracture line was. Okay, so luckily by now she's 16, so you're not worried about causing growth problems because of your osteotomy. So you go all the way across, and then you need to try and get this fragment back into position, and that takes a lot of time and effort. You need to do it gradually so that you don't totally devascularize the fragment. So you actually pull on this with these clamps. You can see I'm holding this with a clamp and pulling as well as trying to lever it out a little bit. And then finally, after struggling for some time, you're able to get it into a reduced position. And then we put in 3 lag screws from anterior to posterior on that, okay? So this is the immediate post-op. This was at follow-up at about 4 months. And then she came back, 4 years later, okay? So she didn't come back in between, and we had to actually call her back to see how she was. And luckily, she is doing really well. The osteotomy is healed. She's got a reasonable, nice congruent joint and a full range of motion and a normal gait at this stage. So we could have a couple of questions on this case, and then I'll just go on to the next case. Is that okay?
Yes.
Yeah, okay. So anyone would do something different or no? Okay, so there's very little in the literature to help us with this. This is a slightly different case where you have a 1-month-old injury in a 9-year-old child, and this was treated with a cast initially. Again, probably the displacement was not really appreciated, and she came to us with a totally stiff knee and a jog of movement. Those are the CTs, and the displacement on the CT there showing you a significant displacement of the posterior part of the medial condyle. And again, the other sections, the 3D, showing you this big displacement. So again, it's a situation where it's difficult to leave it alone at this stage, and you need to go in and do something. We went in through a medial parapatellar incision, and here again, if you see, this is the anterior part of the condyle there, and the posterior part of the condyle there. So there's a huge gap there. You have to freshen this up, do your osteotomy again through the fracture, loosen up that fragment, and then get it reduced into position, and then again fix it, okay? Now, this patient at about 6 weeks had very little range of motion. The physis looked okay at that stage, and so we had to decide what to do at this stage, whether we just wait. We waited for another couple of months, but the progress was not very satisfactory. So we went ahead and did an arthroscopic arthrolysis. This is her at 4.5 months post-op. At that stage, she had just over 100 degrees of flexion, and this is her at 1 year post-op. Again, no evidence of any obvious deformity at this stage. It may be still a little early, and she got back a full range of motion. So I think these are sort of difficult areas. I think the important thing is to avoid missing the diagnosis. The literature is a little scarce on this, and there's one article showing that in adolescents, many of these get missed. They could be mistaken for ligamentous injuries. I think if there's an intra-articular displacement, that needs accurate reduction. You need to warn patients about growth disturbances and observe for that carefully. And if they come late, the reconstructions can be challenging, but there are things you can do to alleviate the problems even at a late stage. Thank you.
Thank you, John. We have time for a question.
Good morning, sir. My question is, in the first case, you shown this intra-articular correction. So why you opted for this in place of extension osteotomy?
Yeah, because you will not correct the intra-articular step-off with an extension osteotomy. Okay, because there was a significant intra-articular step-off. And if you really looked closely at the X-ray, that was impinging on the tibia. Okay, and CT showed it, but intraoperatively it was even more.
Because in most of the cases, when we go in, there is a great chance to get this stiffness of flexion.
True. I mean, so it's a difficult decision, especially when someone's got such a good range of motion, but they're worried about this flexion deformity, and she's reaching that age where they're trying to get her married off, and that is a problem. So in India, that is a big issue. Also, if you cannot extend your knee properly, you're not going to be able to lock your knee, and so you're not going to be that stable on your knee either. So I think it's a difficult decision, especially because if you do risk a problem with stiffness afterwards on a patient who has otherwise a very good range of motion, it is an issue. But
one last comment is, because have you ever noted that the cause of this flexion deformity is that mechanical obstruction of that bump? And
well, even under anesthesia, we were not able to straighten the knee beyond that, okay? So that's what we looked at as well. The CT showed it, and interestingly, at surgery, it was very obvious. Okay, and the step-off was a lot more than we could even make out on the CT.
Thank you.
Sir, one last question.
In your second case, you have approached the patient in the median parapatellar and given screws. Do you think using a posterior approach and putting a buttress place would have been like, what is your comment on that?
So it's difficult to put a buttress, a true buttress.
Not exactly screws
okay,
in the distal fragment.
It's a fascial injury in that part, so it's difficult to put a buttress. The advantage of approaching it anteriorly is you can visualize the articular reduction perfectly. Okay? If you go posteriorly, it's going to be more difficult to visualize the articular part of the reduction because that extends anteriorly. So if you have a very small fragment in the sort of Hoffa type, in the adults we do go posteriorly, but if it's a larger fragment, we still go anteriorly even in the adults so that you can visualize the intra-articular reduction adequately.
Okay. So we'll have to move on to the next one just because of the next ICL. So Sandeep is going to talk to us about Cozen's phenomenon, please. Thank you.
Thanks, Peter. So this is one interesting fracture which I thought everybody should know about. This is a 4-year-old child with an innocuous looking fracture at the upper end of the tibia. And I want a show of hands of how you are going to treat this. How many for in situ cast? Nobody? Okay. A lot of them. How many would overcorrect this into varus in extension and cast? Yeah. Okay. Open reduction? No one. Any of the above depending on the displacement. Right? So what happened with this child was he was treated with a cast in situ. It went to satisfactory healing. But eventually the child developed a valgus deformity. Now everybody should understand what is this fracture. It's a proximal tibial metaphyseal fracture which is a low energy fracture without a fibular fracture. And it has a predisposition to end up with a late valgus deformity. Please understand and know this in your practice so that you don't end up with problems. It was described by Cozen in 1953, and the important part was 3 out of his 4 cases threatened litigation. Right? The importance of this, even in 1953, was that you treat a fracture which looks innocuous, child develops a deformity, and you end up going to the court. Right? So everybody should understand and counsel, and can we do something about it? What are the causes that have been proposed? A few theories said that it's increased vascular response causing asymmetric growth. Some thought it's soft tissue interposition. Some thought it's loss of reduction or initial malreduction. A few other papers said it's tethering by iliotibial band or the intact fibula. Or somebody thought the child was not protected adequately and early weight bearing caused the deformation. What is accepted, the most accepted theory as published by McKeown is overgrowth. Overgrowth on the medial side because of hypervascularity, because most of these cases also end up with lengthening. There is usually 0.4 to 0.5 centimeter lengthening on the affected side. What are the variables that may affect outcomes in these cases? An ipsilateral fracture and an high energy trauma, which can cause an increase in the deformation, but be wary of the innocuous looking fracture. This phenomenon was published intermittently in 1971, again by Cozen, then again by Campbell and Jariwala in 2013, and there have been intermittent publications and reports. It was also published in German literature by Klaus Pasch from Stuttgart, and he said that residual valgus and overgrowth happened in 4 out of 6 of his cases. He advised primary reduction, and he even suggested open revision as required. In established valgus more than 20 degrees, a tibial wedge osteotomy may be necessary, but there is a chance of recurrence. So over and all, a complicated situation to deal with. What about the treatment? What does the literature say? Now, Cozen reduced his children with the knee inflection and gave a long leg cast as per his paper, but Rang recommended a cast in extension with varus overmolding or overcorrection. But neither Rang nor any author have examined effectiveness of this treatment till this paper from Burton, who studied the effectiveness of this treatment and found that in spite of a varus molding, 50% patients still developed a 5-degree valgus compared to the normal side. And they still recommended doing this because it was lesser than what used to happen earlier. So what is recommended is that you give a cast in extension so that you can control the alignment of the limb and put it in overcorrection varus, in spite of which 50% will still get valgus, right? So that is the recommended treatment. The clinical appearance is an asymmetric valgus. What do you do with the valgus? You can observe it for about 2 years with the expectation of spontaneous correction. If it is lesser than 5 to 7 degrees, it may resolve with time, as published in a few papers, but not always. It can cause distal tibial compensatory varus, causing a serpentine tibia. The mechanical axis remains lateral to the center of the knee, can potentially overload the patellofemoral joint. Corrective osteotomies, by consensus, have shown to be having a high rate of complications, including compartment syndrome, and a very high rate of recurrence in spite of doing an osteotomy. So what is recommended today is a growth modulation. Strategies in limb reconstruction published by Stevens. Find out the intermalleolar distance, measure the angles. So he studied, this is the largest series of Cozen's phenomenon, 24 phenomenon in 19 patients. They put 8 plates on the medial side proximal tibia. They achieved correction in all the cases, but after removal, 5 had recurrence. 4 of them underwent redo 8 plates. 2 got overcorrected because they were lost to follow-up and needed lateral 8 plates. 10 of these have achieved maturity and 9 are still being followed up. And the limb length discrepancy towards lengthening was about 5 millimeters. So it actually lengthens. This is the example of growth modulation for proximal metaphyseal valgus. Case 1, which shows you the correction. Another case showing you the correction over a period of time. So some take-home messages for you. Understand this condition. An innocuous looking proximal metaphyseal tibial fracture ends up in valgus. Please counsel the parents in anticipation. Usually, maximum valgus will be seen between 8 months to 1 year. When you're treating, try to reduce and put the cast in varus in extension. You will have 50% success and lesser valgus. After it ends up in valgus, you can afford to observe for 18 months to 2 years for spontaneous correction. Hemiepiphysiodesis with 8 plates offers reliable results, but a strict follow-up is needed till maturity. You can consider removing only one screw because there may be a recurrence, and you can add that screw later if it recurs rather than removing the whole plate. And understand that osteotomies have more complications. Thank you very much.
Thank you, Sandeep. Any questions from the floor?
Interesting, Sandeep. My only question is the usage of the growth plate, the 8 plate. Is that age related? Would you consider that in an older child, or is it just any child with...
At any age, provided you have waited for about 18 months for spontaneous resolution.
And, as a follow-up, you talked about the recurrence.
Yes.
Now, how often do you see this recurrence? I mean,
The paper which has been published by Peter Stevens himself, he saw 5 recurrences in his 24 Cousins phenomenon, which had to undergo a screw 8-plate fixation. So now what he recommends is that once it's corrected, remove only one screw.
Every time?
After correction, because there is some growth still remaining. So that you can just reinsert one screw and it will still get corrected.
So, see, why I'm asking you is, you got 2 surgeries then.
Yeah.
You got to counsel the family that, you know, we're just removing one screw
Yes.
for something which may or may not recur. So
Right.
is it justified to just remove one screw and keep the plate on, even if there is 50% chance?
Right, so that is what is recommended. But the thing is that these phenomenon occur, we need to be aware of these and counsel and treat accordingly. What is published today is growth modulation and removal of one screw if required, if you expect recurrence and too much of growth is remaining. If he achieves maturity, you are done with it, take it out. Yes.
What's your approach on day one when you know that this is going to have a problem? So, while counseling the parents, do you counsel them on day one, like keeping that possibility in mind and counsel on day one, or as you are following up them?
No,
okay, this
always
is going to
counsel on day one in anticipation, because enough literature is published which says that this happens since 1953.
And how frequently you call them for radiological follow-up in initial,
So,
say, a year
so
or
after
so?
the fracture heals for 1 year, you need to follow them up, because maximum valgus has been seen between 8.8 months to 1 year.
So like 3
So
monthly
what you would
X-ray,
do
6
is do
monthly or-
intermalleolar distance measurement. They will come to you saying this looks crooked. You don't have to follow up. They are going to follow you.
Okay.
So the last thing we're going to discuss is forearm fracture malunions, and then we'll have a little bit of time for questions, and then unfortunately we have to move on to the next ICL, which starts at 11:45. So first is pretty simple. Forearm fractures are common, so we all treat them often. It's about 30 to 50% of all pediatric fractures fall on an outstretched limb, as we know. Pretty high annual incidence, and we understand that we define these geographically by anatomic location. So distal third is by far the most common. Middle third is pretty common as well, and then proximal thirds are the least common, but in some respects the most problematic, particularly in the radius. Our goals obviously are simple: fracture healing, so we spend a lot of time talking about risk of non-union, which is very low as long as you don't have an open fracture, dysvascular situation, or that you don't get the bone kind of in the same neighborhood as the rest of the bone for stability. It's really preservation of function, and what we're mostly focused on here, to be honest, is motion of the forearm in terms of pronosupination rather than wrist flexion extension or elbow flexion extension. Obviously, we'd like to avoid complications, and we'd like this to look somewhat normal. One of our criteria is really, in a simple sense, how ugly does this look, and then how well does it move. So anatomic considerations, we know all about remodeling. So the distal radius has significant growth potential. 60-70+% of the growth of the forearm comes distally. So the more proximity you are to the physis, the more likely you are going to remodel, particularly if it's in the plane of motion of the joint. But rotational remodeling does not occur much at all, if at all. We know about remodeling data that's been presented. So distal radial remodeling is at about 0.9 degrees per month, about 10 degrees per year. We know that the mid-shaft is significantly less than that because it's far away from the physis, so roughly about 4.5 to 10 degrees comparatively, so less than half of the ability of the distal radius to remodel over time. We know that bayonet apposition, particularly if it doesn't have malrotation, has tremendous ability to remodel if you're in the right plane of motion. There's been several papers, including a POSNA award-winning paper on this, and so if you're less than 8 to 10 years of age, bayonet apposition will do this, but rotational remodeling is really the major thing we're going to talk about today. And as Mercer Rang taught us, forearm fractures are really first a rotational problem that on our two-dimensional radiographs look like it's an angular problem. But as you get that apex volar supination deformity, your reduction requires pronation, and vice versa. The less common apex dorsal requires reduction into supination to counter this. So what's acceptable based on remodeling? And these are kind of rough numbers, but basically 20 degrees of midshaft angulation, bayonet apposition, no malrotation. Almost always this will take care of itself. As you get older, you have less ability to remodel, as we talked about in the midshaft, and you have less ability to take care of your rotation at all times, at all ages. And as the fracture moves up into the proximal third, it becomes even more problematic. There's a bunch of studies on malunions that say if your radiograph looks awful, but the motion is good and the patient is doing well, that this is fine. And so there's not a one-to-one correlation between the appearance of the radiograph and the appearance and function of the patient. So you can have relatively good functional results with some malangulation and even some malrotation because of compensatory motion, as we've chatted about. But you will have some forearms that are really malunited because they either got an inadequate reduction or they had a suboptimal cast in terms of their treatment, and they had some false assumptions about remodeling that then are very problematic for these patients. So the role of corrective osteotomy is limited, but it's for those patients who won't remodel. They have a rotational deformity. You have to do a rotational osteotomy. They have an angular problem. You have to do a corrective osteotomy of the wedge, sometimes in combination of both, so that you can get and correct this. So we'll just walk through this a little bit. Anatomy first plays out, so the biceps insertion leads to supination of the proximal fragment. Pronator teres, pronator quadratus lead to pronation of the distal fragment, so that's where your malrotation is going to come from. Angular deformity is a part of all that, and so you then have to sort out whether you're going to do a corrective wedge. And sometimes you can get away with a single bone corrective wedge, but most of the time you're talking about both bones if they're bad enough. So this degree of deformity is significant, and there's a marked decrease in range of motion for this patient. And so this is the preoperative planning for us in terms of this angular correction. And then at the end, ideally you have internal fixation. So we tend to do these with plates and screws rather than wires because we then want to move these kids almost immediately with limited external immobilization from casts. So forearm malunions, vast majority of fractures successfully heal. You have to pay attention. Corrective osteotomies will take care of this. So here's another case, forearm malunion. There's a lot of literature that indicates that if you really have an incipient or early malunion, it's probably advisable that you treat that as fast as you can once they have reasonable range of motion at their elbow and at their wrist if you know it's not going to remodel. So is it a problem? When do you need to do something about it? It's really when it's a block to motion that becomes the issue. So here's this kid's acute fracture. Where is it? Where's the deformity? What's the problem? The more proximal you are, the more significant the problem is. How displaced it is fits into this, and how old the patient is. So look at your radiographs. Evans has taught us to look at where the radial tuberosity is in relationship. So the radial styloid to the bicipital tuberosity, they should be 180 degrees apart. And where the coronoid process is in relationship to the ulnar styloid, they should be 180 degrees apart. This can have some degree of lack of perfection, but you can have some malrotation and you'll be fine. Skeletal immaturity makes the technique harder, so sometimes you get into CT scans to help sort out what you're going to do. Extensive literature tells us you can tolerate some of this, but not all of this. We went through the numbers a little bit, and we know that you lose rotational malunion will give you loss of motion in a 1-to-2 ratio. So certain rules we've chatted about, this 25-15-10 for distal proximal and distal mid and proximal. Malangulation, the older you are, the less you can accept, and here we are. So about a 15% malunion rate, less forgiving. You want to take care of this palmar ulnar deviation if you can. Loss of the interosseous space is the problem. Treadwell talked to us about axis deviation, which is outlined here. And so I'm going to run out of time here, but really it's loss of functional motion and impingement pain. Extreme positions, pronation or supination, are really the problem. You need a compliant patient who's going to help take care of this so you get your corrective osteotomy. I would advise early if you have to go there. Most of these are both bone operations and wedge versus oblique osteotomies, and so oblique is a single step. In the interest of time, I'm going to just stop, but you have to decide on plate fixation versus IM rods versus X-fix. And I won't get into distal osteotomies. So floor is open for any questions for me or for any other members of the panel in the next few minutes before we adjourn. This was an outstanding session, so thank you very much.
So I guess the next session starts at 11:45, so we can use 5 minutes for questions on any topics till now, so that.
Sir, my question is on malunited supracondylar fracture. Malunited supracondylar fracture.
I'm sorry, it's hard to hear.
My question is on malunited supracondylar fracture. Many patients of malunited supracondylar fracture have rotational component.
So
Yes, what is your
malunited
question?
supracondylars is what we're going back to that. Sorry.
I want to know. I want to ask about the rotational component.
Would you correct the internal rotation component in a cubitus varus deform? Is that your question?
Yeah.
Yeah,
Which clinical finding we should rely? Loss of supination, loss of shoulder axial rotation, or Yamamoto test.
So if they so I think if they have less than 30 degrees of cubitus varus, then I don't think you have to correct the male rotation component because your shoulder will take care of that. When it gets more severe than that, then I think that's where the dome comes in because you are rotating and correcting the three-dimensional deformity. Okay, so if it's less than 30 degrees, I think you don't have to worry about rotation. Okay.
Okay, so less than 30 you can accept, shoulder will take care. More than 30, correct it.
Correct.
Okay. And sir, which clinical finding we should
Which
rely?
clinical test would you rely on for finding out that there's an internal rotation problem of more than 30?
So which clinical test would I go to? I think, fortunately, most of the kids are ligamentously lax, and so they have the ability to compensate. As you get older, and we were talking about this in the adolescent that you correct, you need internal fixation so you can move them, and you have to have a more definitive correction.
All right, next question.
This is a general question to all faculty. What is the role of BMP in the non-union of fractures in children? What is the role of BMP?
So for us, we tend to use some form of bone graft, oftentimes the patient's own, or allograft. We think that the biology, most of the time, if it's not infected, is sufficient through the periosteum. I don't know what other people's feeling are about that.
What is the role of BMP in children?
None as far as I'm concerned.
I'm with John. I think you can solve a lot of non-unions by finding out what is the reason that the non-union developed without resorting to very expensive substances.
I believe bone grafts contain BMP.
So I had two questions. What is the ideal age for correction of the malunited supracondylar humerus? And second, do we overcorrect the deformity?
So in the supracondylars, for your second part, we don't overcorrect. We make it anatomic to the opposite side because there's not a growth-related issue almost 100% of the time, so it won't regrow back into varus. There are rare cases you might check an MRI scan to be certain there's not a physeal arrest on that side, but that's very rare, so don't do that. I think the ideal kid is more than 25 degrees of cubitus varus, who's got both mostly an aesthetic issue and a functional issue in terms of motion.
So there is no ideal age for correction, or do we wait till the skeletal maturity?
So I don't wait till skeletal maturity. I be certain that they have their range of motion back at their elbow and their wrist and their forearm, and if it's really significant, I think if you do it earlier, a year, 2 years after the malunion, it's just easier. When you get older, what you have is a zigzag deformity that you then have to worry about how do you get it just right.
Right, Sheetal?
So the very last slide that you showed on the distal radius malunion. So one is you expect that it will remodel because it's close to the physis, but we have seen subtle DRUJ issues with mild angulation around that area. and I saw that last slide. What is your indication, or do you think that you can predict a little bit of malunion can give rise to distal instability of the DRUJ in a little bit older patients?
So, terrific question, which would be great to have gotten to, but indeed, your distal radial and joint alignment is very important, right? And you will have some ability to remodel back into the plane of motion, but if you're within 2 years of skeletal maturity, or for sure within a year of skeletal maturity, you're probably not going to, and you're going to have a blocked emotion. And you'll see it both in ulnar malunions and in radial malunions, and occasionally in both. If you correct the skeletal deformity, you will have a aligned distal radial joint almost all the time. And the mistake is to do a soft tissue procedure for that when you still have a malunion.
Yeah, but we have seen that even in younger patients that, the deformity keeps on moving proximal without remodeling.
Yes.
And then maybe that gives a little bit more lever arm for the DRUJ to be unstable.
Yeah.
And
So I think that does occur as well, and so you have to get the bone aligned. And sometimes you have to do a soft tissue procedure, but it's more often you have to get the bone aligned. Thank you.
Okay, Dr. Mukhi?
In a supracondylar fracture, if you have AVN of the trochlea.
So supracondylar fracture, Sandeep, what?
AVN.
AVN. Have you seen AVN trochlea?
So great topic to talk about. So AVNs do occur. They occur with minimally displaced and with severely displaced fractures. The blood supply comes from above down, and they usually don't present until somewhere at least 6 months, but oftentimes 18 months afterwards. And I will tell you, we don't have a perfect solution, but if you can get to them before the whole proximal forearm drifts into the AVN and stop the growth of the distal humerus so the radial head stays aligned, they'll have much less trouble. If it drifts up, they're going to get osteochondral impaction and loose bodies and other problems. And so if you can keep that joint aligned, that's the ideal place to be. But we don't have a perfect solution to it yet. If you do, let me know. I'm very interested.
All right, last question.
Yeah, I want to ask to Dr. Mukhopadhaya about the lateral condyle malunions. When do you in situ fix them, and when do you open them and correct it and fix? Do you have anything about?
Okay, so basically, if you went back some time, I was opening most of them and doing it.
Yeah.
But we've gone more towards with some of the literature out on in situ fixation. So the minimally displaced ones, we would fix in situ. And if they're very late, then I would fix the metaphyseal part and not do anything to the articular part. Okay? You understand? So you would use a wedge there to correct the deformity and fix it so that you get union, but not worry about the articular reduction. I would say certainly after 9 months, I would be sort of hesitant to try to reduce the articular surface unless it's very badly displaced. Okay, so minimally displaced ones, if there's a progressive valgus deformity, I would use a wedge to correct it. If it's earlier than that, you could do an in situ fixation. Okay, but up to 6 months, I still go towards open reduction.
Okay, thank you.
One question.
One last question, yes.
Yeah, in supracondylar fractures, even in anatomically reduced fractures, I found some of the little amount of malunion. How it is possible? Is there any chance of getting malunited without any displacement in the follow-up? Is it possible?
So I don't think you grow a supracondylar malunion, whereas you can do that in an ankle joint fracture that you have a growth-related problem on one side, but I don't think you will have a growth-related problem. If you do, you ought to write it up in the literature because there's only a few cases of that. It's extraordinarily unusual. I want to thank our faculty. I want to thank all of you who participated. This was quite extraordinary. Great start to the meeting.